Like Stan, we perhaps both are grateful that you're able to accommodate us in English, because our Japanese is, well, maybe yours is better than mine, Stan, but no. Mine is, I apologize, and I'm grateful, and thank you very much for that. So let me start by getting us to think about what it is we're trying to achieve with interoperability. If we think about the classical point at which information is captured, the citizen is in the community, and maybe in the future they're part of multiple social communities, and there's a point of care delivery and information is captured there, and that's often where we focus our thinking about design of clinical applications, information systems. And the classical thinking about electronic health records is that we want to reuse that information for continuing care when the patient is either being seen in the same organization or potentially long-term across multiple organizations in one country, in multiple countries. But that view of the electronic health record is probably no longer good enough. And many of you would already know that. Firstly, the citizen engages with many other systems that influence health and healthcare, such as social care services, occupational health services, schools health services, and also citizens are not interested only in information about their illness. They're very focused on wellness. And so it's an important area where information may be captured about individuals. Some of you may be wearing Fitbits and all those tools that allow you to monitor your own health. The traditional medical model ignores that kind of information, and we really need to see that healthcare has to broaden its understanding of the information that we need to be interoperable. And it's also important that we remember that we want to exploit that information, take advantage of it. For example, we need disease registries, we need to monitor quality of care, run screening programs, public health measures which use EHR data. And also we want to use the EHR for teaching, for research in classical things like clinical trials, but also increasingly for epidemiology, for data mining, knowledge discovery. And final, why do we want to do all of this in a joined up way? It's because it currently takes too long for research findings to make their way back into clinical practice. We want to accelerate learning and getting it back into the point of care delivery. And also we want to have things like real-time public health so that clinicians are aware of issues and problems and can respond quickly in the way they deliver care. Things, for example, on the right-hand side, this arrow, like antibiotic resistance patterns, getting emergent resistant patterns picked up by data mining microbiology results, feeding that back into prescribing decision support so that clinicians are deviated away from prescribing an antibiotic that will give rise to massive resistance problems. We're a long way from delivering that kind of solution, but without interoperability, we can't even start. So that's our goal, that's what we're trying to achieve. And of course, as Stan has mentioned, there are many, many kinds of data, and he's mentioned genomic data. So as well as thinking about the landscape, we need to think about the data types, the kinds of information feeds coming in. It's no longer sufficient to think only of the clinician listening to the patient, putting a stethoscope and so on. We're going to get chips where patients have got labs on chips in their home, Bluetoothing that data to their mobile phone, coming off into a collection environment. It's a really exciting time, but it's also a time of challenge for interoperability. So there are all sorts of reasons. Maybe I'll just skip that slide for the sake of time, but there are lots of reasons why we want interoperability. And on this slide, the main point I wanted to make is that apart from thinking of patient care, a number of countries are very keen to do things like benchmarking and compare their mortality rates, their morbidity rates, their clinical outcomes, and if their data are not interoperable, their metrics are not interoperable. And so they look as if they're comparing, but they're not comparing similar things. And another thing on this slide at the very bottom is about the marketplace. We certainly find in Europe that many vendors find Europe a difficult market to penetrate because it has so many countries with very different information standards and information practices. It makes the marketplace fragmented and expensive for them to deal with. So that's all very nice, and that makes it sound like it's wonderful. Let's get on and do it. But why is it difficult? If you think about a diagnosis of chronic obstructive pulmonary disease, so a respiratory diagnosis, and it's documented today in electronic health record, there are so many subtle interpretations that you have to be sure are captured robustly. Of course, it might be a new diagnosis that's been confirmed today on the basis of lung function tests. It could be just a suspected diagnosis based on the patient's story. It could be just one of a few different diagnoses being considered in a list. It could be just a query diagnosis that was written on the order for lung function tests, so it's even less certain than 2 lines above. It could be an excluded diagnosis. It could be just a possible cause of some complication that's arisen today. It could be the indication for a flu vaccine, a condition from which the patient's mother suffers, a risk because of either family history or a lifestyle, just a worry the patient has. So the patient may not have it at all, they're just worried they have it. It may be, and this is something that certainly happens in Europe and the US, an up-coded diagnosis because the reimbursement is higher than asthma, and it could have been asthma, but the physician called it chronic obstructive airways disease. I don't know if you have that gaming here in Japan. You do, okay. So that's another thing. And it could, of course, be a data entry error. So if we're thinking about the electronic health record being interoperable, our job description, my job description, is to say all of those interpretations must be each distinctly entered in an EHR in such a way when it's communicated to another system, it's safe. The receiver can interpret correctly which of those things it is. That's what the EHR interoperability landscape has to do. Thankfully, we've done a lot of work. It's not a brand new field, and we have already in ISO a very good requirements compilation, requirements for electronic health record architectures, which captures a lot of those COPD issues as formal requirement statements. So that's an extremely helpful starting point. And then beyond that, we have information models, reference models for EHR interoperability. Now, half of you in the room, I think, know all about these already, and half of you don't. So I'm sorry for those that are bored. There'll be a little bit of time when you know the next few slides. Others of you will find it very new. So one example of that is a European and international standard for exchanging electronic health records, which has, it's quite a mature standard because there have been a lot of previous versions of that standard. It's growing on 20 years of R&D, and it also does meet the requirements of the standard I put up just now. I won't go into the 5 parts of the standard, but what it does is it defines a hierarchy for the electronic health record, which you don't have to memorize here, so you don't read all the small writing, but it defines a hierarchical structure for an electronic health record. So it basically says that a health record is comprising an extract that has folders, and inside the folders are compositions, inside that are sections, entries, and so on. And it explains what each of those are. And each of those is, of course, formally represented in a UML environment. And then for each of those pieces of the model, we've thought carefully about what information properties might need to be captured in order to position those different statements about certainty, about who the information's about, etc. And so the actual information model then looks more like that, which is not expected for you to read or memorize. No questions on this later. So it's a very detailed model, and like many other models, you know, we've tried to think carefully about how to position all of those properties so they're in the optimal place to be clinically safe when information is transferred. And so, in summary, what that model does is it defines the hierarchy. It describes all about the people, the actors who might need to be doing things such as who the record's about, who the information's about, who's put it in, dates and times of when things occurred to the patient against when things were documented in the record. You have to keep those quite separate. They're very different kinds of dates and times. all sorts of version management properties, so that if the information is created by me and it's sent to 3 different systems, somebody changes it here, somebody changes it there, and later on it's reintegrated. We can track the version history very robustly. Management of all sorts of data types, such as coded terms. We know which terminology the code has come from, which version of the terminology it's come from, which language things were coded in, which units things were measured in, and so on. But all of that stuff doesn't describe the shape of clinical information. We haven't described the clinical shapes, we've just described these medico-legal governance provenance properties. And that's absolutely deliberate, because we do something quite different for clinical knowledge, and that's almost the lead-in that Stan could have had as well. But I'd like to also just turn to another very important family as part of the health informatics landscape, Open EHR, sometimes known as Open Air. And I thought I'd just put a couple of slides up about that. So this is an international community. It's grown since around about the year 2000. There are people in this room who know it inside out and are very actively involved in it and are, you know, part of our lifeblood sitting here. It also has a reference model, a slightly more complex reference model, but importantly, it's been the pioneering environment for something called archetypes, which I'm going to move on to now. So it has a reference model, and this is just one example of the many diagrams that exist for that. But what you will find is that there are things like composition in here, things like section in here, things like entry in here. So there's quite a good correspondence and a relationship between the interoperability standard and Open Air. And this slide is meant to tell you a bit of that, because I'm sometimes asked, oh, is the 13606 standard competing with Open Air? Are these alternative ways of doing the same thing? And it's very important to realize that that's not true. They are seeking to achieve different things. The 13606 standard is the simplest possible model we can achieve that meets all the requirements. It's intended for interoperability between different kinds of systems. So if you like, it's a lean, mean model for transferring data between systems. Open EHR, on the other hand, is almost the richest possible model that's available on the planet. So it's the most sophisticated model, and actually it's ideal for building an EHR repository, an EHR system. So it's not a communications specification, it's an implementation specification for repositories and systems. Very different purpose, but it does actually conform to the above standard. So they are compatible and well aligned, but they also have something in common. They both use archetypes. So what are archetypes? Let's turn to that next. They're clinical models. So having heard Stan now, you might think, we don't need this bit of the presentation. We know what archetypes are, but you just have to live with a few slides, because a bit more detail may be helpful for some. So the idea is that these are shareable models that use the reference model classes but define the shape. How are they put together to actually represent a clinical data structure for a given purpose? And I'll show you a worked example in a moment. The key thing, though, is that unless you have some way of defining the shape of clinical information, if you just rely on a reference model, but say information can be organized in almost random ways by different vendors, by different hospitals, etc., it actually still becomes very hard to try to analyze the data and combine it. It's not good enough to have just a high-level reference model. You have to have the clinical shapes agreed, and that's actually quite a challenge. So the Open Air hosts one of the repositories. Stan has just described another one. This is a mind map view of a whole series of archetypes that exist. And if I zoom in, you might get a sense of a few examples that just give you an idea of the kind of things that it might contain, like body weight, even I can't read it from here, blood gas assessment, fundoscopic examination of the eye, Glasgow Coma Scale. You get an idea. These are fragments of EHR. And along with the data structures, there's a lot of metadata. I'm not asking you to read this, just to give you a sense of the volume. The thing is structured with quite a lot of detail. This is a really very precise specification. So if you were, for example, to think about an allergic reaction to something, an adverse reaction, there is a lot of detail about how that should be documented in an EHR. It really is a tight blueprint that gives everybody a consistent structure which allows for robust interoperability. And our goal is to get medicine charted out in this way so that our EHRs are all consistently created, shareable, analyzable in a safe way. It's not easy, though, to create archetypes, and I wanted to just show you as an example. Let's take pain, and let's imagine we want to create an archetype for pain. And we can start that off as an exercise by picking a couple of examples of clinical descriptions of pain. And then we can just analyze what we have here. So what we have here is a whole set of descriptors of the pain that are now in green. So this, for example, is an onset. So we know that if you're going to create an archetype for pain, we have to deal with the fact that we have to somewhere document potentially the onset. We also have to describe the character of the pain, potentially. We might have to look at where it's located. We also need to consider how severe it might be, how long it's lasted, whether it's consistent or varies by time or other things, and then maybe when it's worst, which for some clinicians, some situations, that's a very helpful diagnostic sign. So if you imagine that we put all of these ideas together, what we then do is to create an archetype, a clinical model that reflects that pain description. So we go to an archetype editor that allows us to build up a little archetype tree, a structure, and for each of the nodes in the tree we can say whether it's optional or mandatory, whether it's multi-valued. So for example, if you want to describe the character of the pain, the patient may give you 2 words, and you may want to put 2 values in for the character. Sometimes it's burning, sometimes it's sharp. So you want 2 values for character of pain. And then we basically build up our archetype tree. And in this case, it's actually a very simple list of properties. So we build that up in an editor, and that allows us to construct the shape of the model. And what you're seeing there is a set of elements. So each of these line items, like location of the body with a T next to it, that means this corresponds to an element in the reference model, and the data value type it has is textual. That means, for example, it could be a coded term coming from a terminology with anatomical locations. SNOMED CT, for example, has those. What we then need to do is to map all of the values potentially to terminologies. So this is, I hope this doesn't make you feel unwell when you see all these words on the screen. You don't have pain, I hope, and I hope this doesn't make you feel you suddenly have pain. But what we would like to do is always to draw the values from a terminology so that the actual words that end up getting expressed in the EHR are coming from a consistent environment. I believe at the moment Japan does not have plans to translate SNOMED CT, but a number of countries do, and the more countries translate it, the more we will then have the ability to have effectively multilingual electronic health records automatically. So that's very exciting. But I also want to tell you why the problem is harder than it looks. So we started off with that little thing for pain, and imagine if we could actually get more inputs on pain. We could get an anaesthetist, a terminal care specialist, a physiotherapist, and a few other people to say, well, tell us a bit more about characteristics of pain that are important to you to document in an EHR. It doesn't take long to end up with something really rather large. And it's even bigger than that, because at the bottom there are a few pluses I didn't expand because I couldn't get it on the screen. So you get an idea that if you really let everybody describe what they want for pain, the thing becomes almost a nightmare because it's so big. And our challenge then is how to balance that. That's our difficulty. Firstly, you know, how many people do we need to speak to and how many inputs do we need to get until we can say the right-hand one, big as it is it complete now? Have we finished asking everybody what they want? When do we get saturation, if you're a qualitative researcher, you know what I mean? When do we get saturation on that? But also, what's useful here? If you imagined a junior doctor in an emergency department and a patient comes in with pain, and one of you has constructed a data entry form for pain description with all of that on it, what will happen? They'll just switch it off. They won't use it. They'll say, where's a free text box? Oh, there's one over there. I'm going to write it all in there. And you'll have no structured data whatsoever. So we've got a real challenge on our hands. How do we get the balance right? And it's slightly worse than this still. I'm sorry to upset you now, make you feel miserable. But actually, the problem is quite large because the EHR or healthcare collects all sorts of information. So yes, we've got examples like blood pressure. I showed you the mind map. The number of archetypes we might need to cover all of the different potential content of an EHR is huge. And even when we think about that, it's worse still because the cardiovascular people, the cardiologists of the world, don't see clinical information in the same way as people who do mental health. So it's not even that they want a superset. They actually might disagree with each other about what they want. And then we've got context, like a hospital admission, which is a very different thing from a general practice setting, where you really want very different levels of detail. So we really do have challenges here in what we're trying to capture in an archetype. But I hope what you're starting to feel is that I've shifted from a challenge of informatics to a challenge of clinical practice. Because this is not really an informatics problem now. This is about clinical consensus and agreement. And I think this is a really important message about where archetypes are today. We think they live in the world of informatics. But if I'm lucky, we've pushed them out into the real world where the real problems lie. We think we've been working hard. Archetypes were born 14 or 15 years ago. And we think we've worked so hard on the informatics. But we've only just started. Probably the sensible thing to do is to prioritize the frequently used fragments. Across this lab, we can't do the whole of medicine in a hurry, but let's pick the bits that people often need and use, and let's start with those and then grow out slowly. And I think that's the only realistic way to do this. And I'll tell you about a project in which I'm involved that's doing that in a moment. But there is one further challenge. If you get experts in a room and say, what should you document? They will be most likely, if you get the right experts in the room, to be looking at the guidelines, the published evidence, best practice, and they will define the archetypes based on what they think doctors, nurses, and others should record. If they were working for me, this is what I would get them to record on every patient. But actually, if you go out on the streets and look at what's in the systems, what you see is often less beautiful, less complete, less precise, less adherent to guidelines. If you want to impose brand new systems using archetypes, and you take this approach, you're also often introducing behavior change, business process change among clinical teams, because they're not always working to best practice. Guidelines take ages to penetrate routine clinical practice. They're working in the lower kind of model. They're doing whatever seems to work best for the moment. So we need to be careful not to position archetypes to be so beautiful, so evidence-based, so perfect, that adoption becomes difficult. Because in the end, it's the junior staff who do most data entry. The people on the lowest salaries with the heaviest workload end up doing most of data entry, and we need to be careful not to position archetypes too severely here. So a project I'd like to just move into for my final bit of this presentation is a European project I'm leading, which is trying to explore some of these issues. And it's a kind of socio-technical project, really. And what we've done is we've taken as an example heart failure. And we've been able to engage the clinicians in heart failure because they care about heart failure and they care about interoperability, because as patients get discharged from hospital, they tend to die. And so good quality information flows between hospital specialists and GPs and maybe heart failure nurses and maybe even with patients themselves, is an important part of trying to avoid that mortality curve. So there is a kind of, there's a human, societal, and business driver for better interoperability. Clinical business driver, not an IT business driver. So what we've done is in the project, we've got some heart failure experts together and said to them, if we want to specify the information needed just for heart failure, so it's a really narrow scope, but even narrower than that, not all of heart failure, just heart failure shared care. So not all the clever stuff you do in a hospital, just the things you need to communicate between care practitioners. What do you need? So that is the challenge we got them to work to. They've gone through all the guidelines. These are European leading figures in heart failure. They even wrote some of the guidelines themselves. And they travel across the Atlantic, and I know they've also interacted with the American Cardiology Association on its guidelines. And what we've done is we've tried to get them to specify what they want from an information point of view. Now, the clinicians didn't draw this diagram, as you can guess, and I'm not asking you to look at the diagram, except to get a sense that they've tried to understand what they need in order to confirm the diagnosis, communicate the diagnosis, communication, the management plan. And from this kind of work, they've gone on to define a data set. So what we've got now is, I'm not going to spend time on this data set, but I just want you to sense it, sense how big it is. I'm going to go through 5 screens, I think, quite quickly. Just quickly look on the left-hand side and you get a feeling for the kind of information they want. So they've basically defined all of these different things. The ones in grey are not always needed, so that's why they're in grey. Things they want to investigate, treatment planning, so there's the, you know, what's the patient got to take, but also what are we trying to achieve, our targets? What's our goal for this patient? For example, what weight, what resting heart rate do we believe is realistic to target for this patient? So anybody who's seeing the patient in another hospital, in another city sometime, knows what the therapeutic goals are for this patient. And if their patient is deviating from that, they know they need to alter the medication and so on. And then there can actually be instructions. So if a patient's discharged, do this, and then if not, do something else. So we're starting to look here almost at rules rather than data items. So what we've done is we've got then a whole series of standards development organizations to come together and try to represent that, which was great fun. Well, it is great fun. So we have HL7, we have OpenEHR, we have EN 13606, we have IHTSDO, WHO, and others, all in the club. And we've set, and I said, when I set up the project, I said, if you join the project, we have to have an agreement. The clinicians are the masters and you're the slaves. You have to develop the standard archetypes, HL7 templates, value lists that meet the clinical need. If you don't like what they've asked you to do, it's tough. The clinicians are in charge. You have to build what you can. And of course, we knew we would hit the classical, it's sometimes called a boundary problem. Terminologies have not been developed over the last 20 years expecting to be plugged into information models. So they've been built in an almost information model independent way. And similarly, many of our clinical information models and underlying EHR models were not really built with a view that terminologies existed. And so often you find that there are quite a lot of the properties I said a reference model has are hiding inside terminology space. And you find a lot of very terminologically relevant semantics is sitting inside information models. And that gives rise to the problem that you perhaps already know, that you can have clashes of representation, or a vendor may find there are 2 ways of expressing the same concept in a more structural or a more terminological way in the same clinical model. And that can give rise to disaster because you've then got non-interoperability. You've defined a model, but it's used differently by different people. And then, of course, it's worse because you've got things like negation and planning and so on. I won't spend time on this, but you know, it's not easy to do this. There's maybe an example of the kind of thing I meant. So here we've got a suspected heart failure. Here we've got a a single coordinated term, a single term expression that has everything in. Here we have it split into 3 different components. And try to glue these together is the challenge of interoperability. What we want to do is to try and avoid having 3 different representations, because that's only 3 examples. You could imagine there could be 10 others by different vendors. If we can define our clinical models in a consistent way, we're telling the vendors, whichever one it is, you know, maybe it's this one. We're saying that's the way heart failure is to be represented. Doesn't matter what you do on the screen, when you store it, when you communicate it to others, do it like this, then everybody's doing it the same way. And we therefore minimize the number of mistakes, we minimize the risk to patient safety. That's the goal. So, that's the list of organizations we have involved in the project. Sorry, maybe I should have had that slide earlier. So you can see a number of bodies. I missed out IHE when I was speaking to you earlier. And then we've also got a set of complementary expertise. Apart from the cardiologists, we've got academics, we've got vendors in the community joining with us, and other bodies. Because we want to try and look at this as a case example. So this is now my last slide. What we're doing in this project is not really trying to tackle heart failure. I mean, it's nice that we might end up with some great clinical models for heart failure, but that's not our real goal. Our real goal is to understand the methodology. So this is a case study, we're learning from it. How do you get clinicians together in a room to brainstorm and come up with what they need? How widely do they have to consult? How easily do they come to consensus? What are the best ways of facilitating that consensus? And then, when you shove this across to the SDOs, what are the methodologies they adopt to try to have aligned standards which don't clash, which don't have inconsistencies? And then when these standards and value lists have come up and clinical models, how do the clinicians know they've got them right? So in fact, we have a meeting next week where we're starting to look at the evaluation methodology. How will the clinicians evaluate a set of clinical models and value lists? Because they're not geeks, unlike us in this room. They're clinicians who don't really understand informatics. How do we help them to be confident that what's been developed for them does indeed meet their needs? And that's a challenge. We have to figure that out. But what we then want to do is to move on, because we know that doing heart failure, that's not going to solve very much for healthcare. So what we need is a scalable and sustainable approach. And I'm sorry, if I'd known a health economist was in the room, I'd have brought in another slide or two, because what we've been looking at is what is the sustainability of this effort. We've got European funding to be able to do this piece of work as a case study. But you know, to scale up, it cannot rely on public funds, because that's not scalable. It's unaffordable. It eventually has to hit the marketplace and enter the marketplace as a self-sustaining environment. And it's complicated to do that. So we've been looking at actually setting up an institute, a not-for-profit entity, that would champion doing this kind of work, at least at the moment at a European level, because that's our current landscape, but there's nothing about what I've described to you which is Europe-specific. You know, this is a global challenge, and clinical practice is much more consistent globally than it is locally. In other words, cardiologists across 50 countries can more easily agree than a cardiologist and a GP in the same city. They'll fight. You know, so that's probably a global situation. So we've been doing things like business model. You probably know business model canvas. You know all of these instruments that you're the economist. Yeah. So we've been doing stakeholder segmentation, value propositions, looking at this thing. I'm picking up the language. I'm learning. You know, multi-level markets and how they're represented and managed. You know all this stuff, I'm sure, inside out. It's complicated because why is it complicated? Because the people who invest in interoperability do not themselves gain the benefit. A hospital that invests in an upgrade to their system to make their systems interoperable can then send discharge summaries electronically to the GP. The GP is the beneficiary. The hospital doesn't get anything for that investment. They support everybody else getting data out of the hospital. But unless somebody else invests in interoperability, nothing's going to come into them. So how do you play the value chain in such a way that you can get not just a value realization, but something that will eventually fund this effort. That's our, we're struggling, but we're working on it, and we're optimistic we'll get there. So we do want to make this thing happen. But as you can see then, that was my last slide, that the challenge is a socio-technical challenge. We've got to take it out of geek land and get it out into the real world, because the people who are really going to call the shots are the clinicians, the health insurers, the ministries, the vendors to some extent, CEOs of hospitals, not CTOs or CIOs of hospitals. And none of them speak geek. So that's our challenge. Thanks very much.